Dear friends and colleagues, today I'm going to share with you one of my cases for immediate implant placement for the upper canine. As we see here in the X-ray, we have a very thin labial plate of bone in addition to a granulation tissue at the very apical side of the root. We should be very careful at the time of extraction to avoid any labial dehiscence. We start with incision and reflection of the flap to avoid any laceration of the soft tissue at the time of extraction. Due to the long time neglection of the remaining root, there is a lot of granulation tissue and fibrous tissue around the neck of the tooth. We can use fine scaler CK6 or ultrasonic scaler for removal of the granulation tissue and the fibrous tissue. Then we start with a traumatic extraction using periton, mesosurgery, or straight elevator with a very controlled force to luxate the remaining root. Avoid any fulcrum upon the labial and palatal plate bone, and also avoid any fulcrum related to the upper lateral incisor not to have luxation for the lateral incisor. We can do also root planning for the adjacent teeth to help the bone graft to heal in the interproximal area. After root fixation, we can use either the upper remaining root forceps or the bilateral forceps or any other way for extraction according to the dentist preference. After extraction, we use a surgical curette to remove any granulation tissue at the very apical site. In addition to, we can do bone sounding for the labial plate of bone to be sure that we do not have any dehiscence. If we have a dehiscence or not, it is also preferred to do augmentation and guided bone regeneration by applying a membrane at the buccal site and grafting all the way. Implant position should be more related to the palatal plate of bone. Here we are going to use 16 millimeter implant because of the very long root of the canine. If we have interference of the handpiece with the adjacent teeth, I prefer to use the drill extension to have free movement of the osteotomy. We can see here the osteotomy hole. All the way we should be very careful related to the angle of the osteotomy, either mesiodistal or buccopalatal. After we finish the osteotomy to the desired depth, we start with the implant placement, either engine driven or using the ratchet or using the hand driver. Using the hand driver should be done with enough support and guard to the full desired length of the implant. Then we remove the implant mount. If you have low torque insertion, you can do extra support for the implant mount, not to have any unscrewable force. Then we apply the cover screw. Then we start with the augmentation procedure. We adjust the membrane to the desired diameters, inserted all the way to the buccal plate of bone. Then start with augmentation. I prefer to use allograft, demineralized freeze-dried bone allograft. Mix it with saline or with blood. Then we suture as usual and cover the surgical site with either periacryl or periopink. Thank you, my colleagues. Please do not hesitate to contact me if you have any question related to my cases, either upon the YouTube or through my email. Hope to see you soon. Thank you, my friends.